Welcome everybody to, I guess, the penultimate seminar of the semester. Today we have Dr. Guang Lo, who's going to be speaking to us about computational approaches for asthma care management. Um, Dr. Lo obtained his PhD degree in computer science with a minor in mathematics at the University of Wisconsin-Madison in 2004. Between 2004 and 2012, he was a research staff member at IBM, and between 2012 and 2016, he was a faculty member at DBMI at the University of Utah. Gang is currently a professor in the Department of Biomedical Informatics and Medical Education at the University of Washington. His research interests include health/clinical informatics, machine learning, big data, information retrieval, database systems, and data mining with a focus on health applications. He invented the first method to automatically provide rule-based explanations for any machine learning model, prediction with no accuracy loss. The first method to efficiently automate machine learning model selection, the questionnaire-guided intelligent medical search engine IMED, and intelligent personal health record and SQL, as well as machine learning and compiler progress indicators. So thank you very much, Dr. Lowe, for agreeing to present at the seminar, and I'll leave it up to you. We usually leave about 5-10 minutes at the end for questioning, but feel free to indicate if you're happy to take questions throughout the seminar. Thank you.
Okay. Yeah, I'm happy to take questions during any time during the seminar. And also I will leave time at the end of my talk to answer any additional questions. So thank you very much for the introduction. So today I'm going to talk about our work on using computational approaches to optimize asthma care management. So let me first introduce myself. I'm a computer science PhD working on health informatics. I work on system building and data analysis. And in general, I work in 5 different areas. First, about information retrieval. We build a medical Google for various healthcare applications. For example, we build a medical search engine to simulate the way doctors interact with patients by giving questionnaires, asking questions to the patient, and the patient click one out of multiple possible answers to the question. So through this interaction process, we figure out what the patient wants to ask. So we automatically generate the search keyword phrases for them. So through mouse clicking, instead of having to type medical terms that consumers are familiar with, so we can help consumers find their desired healthcare information faster. We also develop heuristics to help people quickly find needed medical information using existing search tools. I'm a database PhD, so I work on medical database design, how to write SQL queries and implement them so that they can be run faster. I have some work on natural language processing, also called text mining, such as extracting symptom information from VA clinical notes. Also, we can automatically generate medical text, such as warning messages based on the patient's healthcare condition. So this is in general called a natural language generation. I work on data mining to find informative patterns in medical data. We also do clustering. And today's topic is about machine learning. In general, machine learning covers 2 topics, classification and regression. Classification is about predicting categorical valued outcomes, such as among all asthma patients, who are likely to incur hospital encounters for asthma next year. If we change the prediction target to a numerical value, then we are essentially doing regression, such as predicting a patient's future healthcare cost. So now let me give some background on asthma care management. In the US, asthma affects about 8% of adults and 9.6% of children. So asthma causes over 2 million emergency room visits, about 500,000 inpatient stays, over 3,000 deaths, and over $50 billion in healthcare costs every year. Our goal is to reduce hospital encounters, which includes both inpatient stays and also emergency room visits. So this is highly desired because most of the healthcare costs for asthma occur because of hospital encounters. So this is the state of art of asthma care management. People use predictive models to identify beforehand among all asthma patients who are the high-risk patients who are likely to have bad outcomes in the future. Once those high-risk patients are identified, we put them into a care management program to give them tailored preventive care. And this approach is widely used in the US. Once a potential high-risk patient is enrolled in the care management program, we have dedicated nurses called care managers. They call the patients regularly to help patients book appointments and schedule health and related services. If we do it in the right way, we can cut the patient's future hospital encounters by up to 40%. However, care management is very expensive. Even 20 years ago, doing care management for a single patient for a single year will already cost over $5,000. And now it's even more expensive. And we can provide care management to a very limited number of patients, typically around 1% to 3% of all patients. This is because we have a limited supply of care managers. For example, at the University of Washington, in total, across all diseases, we have about 25 care managers. At the Intermountain Healthcare, which is the largest healthcare system in Utah, they have about 70 care managers. So there are gaps in identifying high-risk patients. The first problem is that the models are typically inaccurate. So this will cause misclassification, unnecessary costs, and suboptimal patient outcomes. So for the previous models, the area under the receiver operating characteristics curve is less than 0.8. So those models are used to predict hospital encounters in asthma patients. So the consequence is that if we use those models to identify high-risk patients, we will miss more than half of the patients who will indeed incur hospital encounters in the future. So those patients will have suboptimal outcomes because we don't give them preventive interventions using the care management program. At the same time, the model will incorrectly classify many patients who will not incur hospital encounters in the future as future hospital users. If we put those patients into care management program, we will incur unnecessary care management costs, which are very expensive. The second problem is that the predictive models give us the prediction result, but they don't explain why a patient is likely to incur bad outcomes next year. This is a particular case with machine learning models, and this creates a huge hurdle for clinical deployment. As a care manager, she needs to know why a patient is at high risk for poor outcomes so that she can make care management enrollment decisions, as well as identify suitable interventions for the patient. Those suitable interventions are used to address the reason why this patient is at high risk, and different patients are at high risk for different reasons. So in our work, we make two contributions. First, we developed more accurate models to predict asthma hospital encounters in asthma patients. We also developed an automatic method to automatically provide rule-based explanations of all models' predictions. So we do not only give the prediction result, we also explain why. In addition, what's unique of our approach is that we can automatically recommend tailored interventions for the patient without losing any prediction accuracy. Among all the automatic explanation methods that have ever been published in the literature, our method is only one that can automatically suggest tailored interventions. And our method is general. It works for any machine learning model that's built on tabular data. So now let's first describe how we improve the model accuracy. We use several approaches. First, we use many data instances, over 300K data instances. This is at least one order of magnitude more than what's being used to train previous predictive models. Second, we use machine learning instead of statistical method. And third, we use many candidate features, over 200 of them, covering various aspects, such as risk factors for asthma exacerbation reported in the literature, features used in the existing models for predicting asthma exacerbations, factors impacting patients' general health status mentioned in the literature, and features suggested by the clinical experts in your team. So this, again, the number of candidate features we consider is one order of magnitude more than what has ever been considered in the previous model. We use machine learning approach. Machine learning is a hot topic these days. It uses algorithms that can automatically improve through experience or the model training process. So typical machine learning models include support vector machine neural network. The model name for it, for a neural network with multiple layers, is called a deep learning. We have decision tree. We can also have multiple decision trees doing voting together. This is called random forest. So compared to traditional statistical methods, machine learning methods often achieve higher prediction accuracy by putting less strict assumptions on data distribution. So we consider the 39 default machine learning classification algorithms that are included in the Weka machine learning package. We also consider the XGBoost classification algorithm. We previously developed a method that, given a data set, we can automatically select the machine learning algorithm, feature selection techniques, and hyperparameter values for the machine learning algorithm among all applicable ones. So we use this approach to do automated model selection. And here are the categories of candidate features we considered in our model building process. We consider patient demographics, such as age and gender. We consider features that reflect properties of the area related to 5-digit zip code of the patient's home address, such as the area's population size, Black population percentages, etc. We consider features that reflect properties of the census block group where the patient resides, such as within this block groups, the number of employed people who are 16 years and older, and within this group, the percentage of employed people who are 16 years and older in a white-collar occupation. We consider lab test-related features, such as the number of lab tests and the number of lab tests with abnormal results. We consider vital sign features, such as the maximal diagnostic blood pressure, the average diagnostic diastolic blood pressure, etc. We have diagnosis-related features, such as the duration of asthma, which is defined as number of years that a patient had asthma. The number of ICD diagnosis codes, whether the patient has a particular diagnosis code, such as COPD diagnosis code, etc. We have medication-related features, such as the number of asthma medication orders that have been placed on this patient, the number of units of asthma medications ordered for the patient. We have insurance-related features, such as the primary payer's insurance category, whether the insurance is public, private, or self-paid, or charity, the number of insurances of the patient at the last visit, etc. we have visit type related features such as number of emergency room visits, the
Dr.
number
Lowe,
of inpatient stays, etc.
sorry to interrupt. So we have a couple of questions in the chat. Do you want to take them now, or shall we wait for another period and to take them?
Oh, okay. So let me check them one by one.
Okay. I'm
So the first question is how does the care management cost compare to hospitalization cost per patient per year? About 20 years ago, the care management cost for a patient is $5,000 per patient per year. But if the patient is ever put into an inpatient stay just once, it will cost much more than that. So the reason we want to do care management, uh, one motivation is that we want to improve outcomes. The other reason is that care management can help reduce bad outcomes. So financially, it will reduce the total healthcare cost. So the hospitalization cost is way more than the care management cost. Um, Okay, so the second question is, as asthma patient populations include both adults and children, have you observed any notable difference between adults and children? And do we handle these two patient populations differently for model building and when designing interventions? So first, for model building, we tried two different approaches. One is that we build a single model that cover both adults and children. And the second approach is that we build one model for children and another model for adults. We tried both approaches and we got similar results. And actually, if we put them together, we can achieve higher prediction accuracy because the number of patients become bigger. So in our published result, we only provide a single model. And this model's performance across children and adults, the performance are very similar. And for interventions, in general, almost all the interventions are the same for both children and adults. And they're, for a very small number of reasons, the interventions tailored for this reason can be different across children and adults. So this can be considered, but this is very easy to handle because when you display the reason, you know the patient's age. That's one of the factors considered in the model. So we can display the interventions suitable for this patient based on the patient's age. The next question is, what's the percentage of population who is Black included in the model? We built a model across 3 different sites. One model built for University of Washington data, one model built for Kaiser Permanente Southern California data, and one model built for Intermountain Healthcare data in Utah. So in different data sets, the percentage of patients who are Black vary a lot. So those are reported in our papers. I don't have the numbers in front of me, but those numbers, because we have patient demographics data reported in the papers. How is white collar occupation defined? So the white collar occupation, that's the number that's used to in one of the features related to the patient's the area that the patient lives. So given the patient's zip code, we can get this number directly from an existing database. And that database is publicly available and widely used. So we do not make any modifications. So that means how we define white collar occupation, etc. We are not doing this specifically using our own definitions for our medical database. Instead, we just get it from a public database that's linked to the zip code. And then how did you ascertain duration of disease, ascertain duration of disease? This one, So we have data across many years. In some data sets, we have data over 10 years. So we just get the earliest, for a particular patient, we just get the earliest year in which the patient had asthma diagnosis. We use that to compute the duration of asthma that the patient has had. Okay, that's all questions. Okay, so let me continue. So here we also use features related to appointment scheduling and visit status, such as the number of no-shows, number of canceled appointments. We have features reflecting care continuity of the patient, such as number of distinct emergency room visits that the patient ever visited, the number of distinct providers that the patient ever seen in outpatient visits. We have procedure-related features such as number of ICD procedure codes, number of CPT procedure codes for pulmonary function tests, etc. We have radiology-related features such as number of chest X-ray exams. We have allergy features such as whether the patient had any drug or material allergy, the number of allergies of the patient. We have clinical assessment related feature such as the number of times the patient was assessed to be confused. We have provider features such as whether the patient and the patient's current primary care provider are of the same gender, the age of the patient's current primary care provider. We have facility features such as the distance between the patient's home and the closest emergency room, and the distance between the patient's home and the office of the patient's current primary care provider. So once we build the model, we can do automatic explanation. So this is how our method works. So previously, we developed a method to do automatic explanation. So the idea is that we use two models instead of one model to separate prediction and explanation. The first model is whatever model we can use to make the most accurate prediction. So the goal is to target maximizing prediction accuracy. We don't want to sacrifice prediction accuracy at all. Once the first model makes prediction on a particular patient, we use the second model to give explanations, say why this patient is predicted to have a particular outcome. And this second model is based on association rules. It is only used to explain the first model's prediction result. The second model does not make predictions by itself at all. Association rules are originally developed in the computer science community for market basket analysis. For example, when we as customers go to Walmart, we get a shopping cart. We put items into shopping cart, then we check out. And the shopping market basket analysis use association rules to identify which several items are frequently bought together by many customers. So we use this approach to identify which several factors occur frequently together that are linked to a particular outcome, such as a bad outcome. So one example rule can be, we have two factors. The first factor is that in the past year, the patient had at least 12 emergency room visits. And the second factor is that in the past year, across all asthma medication orders, the patient had at least 21 distinct medications. So if both factors occur, then we say the patient will incur asthma hospital encounters in the following year. We have a historical data set that's used to train model. We can use the same historical data set to mine association rules that are used in the second model. Once the first model make a prediction on, say, new patient, we can find across all the association rules, the one or more rules that are applicable for this patient. That means the patient satisfies all those conditions in the rules for this particular outcome. And those association rules are used to explain the prediction result for the patient. And because all those association rules are mined beforehand, so they are known beforehand. And we can get all those association rules, check them one by one, check all the reasons listed in those rules. And based on those reasons, we can ask clinical experts to compile tailored interventions suitable for those reasons. And then we put those interventions into our database. When a new patient comes in, we make a prediction. We find the reasons why this patient is at, say, a bad outcome using association rules. Then we can find all the tailored interventions that are linked to those particular few association rules that are tailored to this patient, that are displayed to the patient. So those are the tailored interventions we can suggest for this patient. And those tailored interventions address the reasons listed in the rules. So the previous method was originally designed for reasonably balanced data. So that means, for example, if we have yes and no as two possible values of the outcome, those two values appear with roughly similar frequency. But when we try to predict asthma hospital encounters, the data are very imbalanced. The yes value, the bad outcome, appear much less frequently than the no value, means good outcome or no hospital encounter next year. So among all asthma patients, only about 4% of them will have asthma hospital encounters next year. So the yes value is about or no more than 4%, and no value is 96%. So the data are indeed very imbalanced. So for association rules, our previous method used the standard method. So each association rule cover at least a given percentage of data instances and also fulfill a given minimal accuracy threshold. But if we have imbalanced data, this traditional approach will cause insufficient number of association rules to be produced for the rare value of the outcome variable, which means that the rare value is the yes value, that the patient will have bad outcome next year. So that basically means for a large proportion of those patients who are predicted by the first model to have bad outcome next year, we cannot give any explanation. This is not desired. So we change our previous approach so that the new approach can handle both balanced data and imbalanced data. So the idea here that each rule here should cover at least a given percentage of data instances that link to the rare value of the outcome variable for asthma hospital encounter, which in this case means the patient will have asthma hospital encounter next year. So it's not covering at least a certain percentage of data instances, but a certain percentage of data instances that link to the bad outcome. Then for all the data instances that link to this particular value, the bad outcome, we mine the candidate association rules. Then we filter out those association rules whose accuracy is below a given threshold. Then in this way, we can get each association rule to be first accurate enough by itself and also link to a sufficient number of data instances that link to the bad outcome value. In this way, our approach can handle imbalanced data. Now let me show the performance results. So the previous model, the AUC area under the receiver operating characteristics curve is never greater than 0.8. And we have 3 different data sets, one from Intermountain Healthcare, which is the largest healthcare system in Utah. There we get the AUC of 0.86, which is at least 7% or more improvement compared to the previous model. At Kaiser Permanente Southern California, our AUC is 0.82, which is at least 3% or more improvement. And at the University of Washington Medicine, our AUC is 0.9, which is at least 11% of improvement. Across all those three sites, the patient characteristics vary a lot. So that's the reason we suspect why at different sites, even if we use the same computer science approach to build a model, the AUC we got is different. And also those different sites manage patients very differently. For example, at the Kaiser Permanente Southern California, they have very special program. They spend a lot of money to manage asthma patients. So their patients are better managed compared to many other places in the US. So this may make it harder for us to more accurately predict those patients' outcomes, because those patients may be managed in a more they are better management, so which it makes it harder for us to predict outcome. So that's the reason we suspected. And then about automatic explanation, we cannot automatically explain the prediction result for every patient that is predicted to have bad outcome next year. This is because association rules by design can only cover common patterns. That means we can only find the common reasons or combinations of common reasons that are linked to bad outcome next year. So if we use our approach at Intermountain Healthcare, we can explain 90% of patients who are predicted correctly to have bad outcome next year. At Kaiser Permanente Southern California, this percentage is 98%. At the University of Washington Medicine, this percentage is also 88%. So those percentages are not 100%, it's imperfect. But on the other hand, when I talk with some clinical experts, they also told me that when they try to make predictions on patients, they cannot always explain why they make those predictions themselves. So even for clinical experts, they cannot always give explanations for what they predicted. So this randomly chosen example of automatic explanation. So you can see in the real world how this looks like. So this is an association rule that contains 5 factors. All those 5 factors combined together imply that this patient is likely to have a hospital encounter for asthma next year. So the first factor is that for the patient's most recent visit, the time from making a request to the actual visit was less than or no more than 0.6 days. The second factor is that the patient's lowest SpO2 level during the past year was between 94.5% and 95.5%. And all those numbers, 0.6, 94.5%, and 95.5%, those are automatically discovered using the association rule approach. So we don't manually assign those numbers. Those are discovered from the data set automatically. The third factor is that the patient is a Black or an African American patient. The fourth factor is that the patient was prescribed asthma medications at least 16 times during the past year. And the last factor is that the first encounter related to asthma for this patient was from at least 1 year ago. So now let's check those 5 factors one by one. So the first factor, the patient was in a rush to make an appointment. So there's very little time that has ever elapsed between making an appointment to the actual visit. It's no more than 0.6 days. So this means the patient had urgent appointments, indicating that the patient had acute conditions, has delayed seeking care until absolutely necessary, or lacks access to care. Then the pre-compiled interventions suitable for this reason includes ensuring that the patient has a primary care provider and is scheduled for regular follow-ups, assess the patient's need for referral to specialists or home care, and provide education managing asthma and resources for care. So for this particular patient, if we find this association rule that's used to explain why this patient is is likely to have bad outcome next year, then those are the interventions we can automatically suggest for this patient. The second factor says that the patient's SpO2 level is low, it's around 95%. This indicates worsening of symptoms or other complications, such as hypoxemia. And the pre-compiled interventions for this reason includes evaluating the patient for cardiopulmonary cause of hypoxemia, considering nighttime oximetry or sleep study to evaluate the patient for nighttime hypoxemia or sleep apnea. And we can assess the patient's need for home oxygen or nighttime non-invasive ventilation. The third factor says that the patient is Black or African American. And it's known that among those patients, they are likely to have poor respiratory outcomes and low quality of life. And the pre-compiled interventions that can be used to address this reason includes ensuring that the patient has needed resources and access to care. And we can assess the patient's need for social work or home care. The fourth factor says that the patient use many asthma medications. This can indicate ineffective regimen, poor treatment adherence, or a poor control of the disease. And here are the 5 interventions that are pre-compiled for this patient to address this reason. The first one is simplified asthma medications to once-a-day formulations or combination medications. The second one is to address concerns for adverse interactions between medications. The third one is to provide patient education on correct use of asthma medications or inhalers. The fourth one is to consider strategies to improve medication adherence, such as using a pill organizer or providing reminders for taking medications in time. The fifth one is to do medication reconciliation review by a medical doctor or a pharmacist. So in conclusion, our goal is to reduce inpatient stays and emergency room visits for asthma patients so that we can improve patient outcomes and reduce healthcare costs. In order to make care management more efficient for asthma patients, we provide more accurate predictive models. We also provide a method that can automatically explain the model's prediction result for a particular patient, as well as automatically suggest interventions if the patient is predicted to have a bad outcome next year. So those automatic suggest interventions and explanations can help care managers review patient charts faster and create patient management plans more efficiently. A patient with a long history can have hundreds of pages in the patient's chart. So it's very labor intensive for a care manager to manually review those hundreds of pages. For example, how many encounters the patient had, how many medications the patient have ever had for a particular type. Those things, if we ask the care managers to manually compute, it's very hard. But here we are using computers to automatically summarize the hundreds of pages of information into a few numbers, and then we can display those numbers as reasons why the patient is likely to have bad outcome next year. So this makes it very easy for the care managers to know what's behind our model prediction result. And in general, there are many possible interventions that can be applied to a patient. If the care manager has to think by herself in a few minutes, it's very hard for her to not skip any intervention that could be useful for the patient. The care manager may miss some interventions, but we display all those potentially useful interventions for the care managers to choose. So these are essentially a reminder system to reduce likelihood that the care managers forget something that can be useful for the patient. And we just use asthma care management as a test case. But in general, our approach can be used to manage other chronic conditions, such as diabetes, COPD, etc. So for example, on University of Washington medicine data, we obtain very similar results for COPD in terms of model accuracy, as well as the automatic explanation capabilities. So in general, if you have a particular disease, you want to make a predictions for a particular healthcare purpose, it's likely you can use our approach to build more accurate models, as well explain the model's prediction results, as well as automatically suggest the tailored interventions suitable for the patient. So thank you very much. So now this is the end of my talk, and I'm happy to take any additional questions. Jeff?
Wonderful. Thank you very much, Dr. Lowe, for that very interesting talk. If you have a question, either feel free to put it on the chat and I can read it out, or feel free to also just unmute yourself and ask the question as well.
I had a quick question. First of all, I think very interesting model and very impactful work. Have you considered any other type of environmental data, like I don't know, maybe regional environmental data, maybe forest fires, things like that? I also know asthma can be quite seasonal, so I was curious if you had any seasonality component of your models as well.
So those data sources are not included in the current model building process. They can be interesting for future work. But on the other hand, we are not sure whether those data sets will give you additional predictive power. So we have done some asthma outcome prediction for another outcomes several years ago. At that time, when I was at Utah, we added environmental factors, but those factors does not improve model accuracy. But here, this is a different outcome. So it's hard to say whether those environmental factors, because in general, if you have different features, there may be prediction power redundancy across different features. So it's hard for us to tell, say, whether the current features that are used already includes the predictive power that is redundantly covered in the environmental factors or not. We don't know yet.
Makes sense. Thank you. And then the seasonality component, I would also be interested in. I know in this case, it seems like you're predicting on a yearly basis, so that
Right.
corrects for that. But have you tried to do it on a monthly basis or a quarterly? And do you think, or yeah, I'm curious if you've tried to address it in other ways, basically.
I think we did some studies showing each a poster which shows, say, if we make predictions over time, how early can we predict if the patient indeed will have bad outcome, how early, by what time we can make predictions. And we show a curve saying, say, how many patients we can predict, say, how many months ahead of time. So there's a curve like that. And this partially addresses the seniority issue, although it's not exactly the same as what you are talking about. So there's some kind of distribution about the predicting capability over time based on the patient's condition.
Makes sense. Thank you.
Hi, thank you for your presentation. My question is whether or not this, I guess, model has been piloted already, and if you saw any cost savings associated with it, if it has been piloted.
So it hasn't been put into clinical implementation yet. So this is something we are very interested to do, and we are working on it, but it's not done yet. So without doing an actual clinical implementation, we will not have actual healthcare cost saving numbers.
Thank you.
Yeah.
Great. Is there anybody else who has a question? You can either unmute yourself or post it.
Yes, and I may miss this. The interventions that you're recommending, how were those defined and selected?
So those interventions, for example, we have this, because those association rules are mined from historical data. So when new patient come in at the time we need to make a prediction for new patients, all those association rules are already known across all patients, so that all those factors are also already known. So we have clinical experts who compile those interventions for each individual factor beforehand. Yeah.
Okay, so it's based on expert opinion, presumably looking at best practices for those particular risks that are identified. Is that
Right. So the asthma doctors wrote those interventions to address every particular factor.
okay? Just a, really just a comment. I mean, maybe they are written at this level. It's kind of interesting that, most seem pretty prescriptive and you're identifying kind of patient risk. I wonder if, as you go to implement, there might be opportunity for seeking more information, right, from the patient. Why is this a problem? As opposed to more prescriptive interventions based on these risks identified. Right, why is medication adherence a problem for a particular patient? And then that often can help navigate more so effective interventions.
Yeah, so those are the things that I think once we go to the pilot testing stage, we can get to know more because we will receive feedback from patients and the care managers. So currently, we only have very small number of asthma doctors who wrote those interventions.
Okay, yeah, and certainly that work with care managers will be important. Great.
Yeah, thank you.